Good afternoon and welcome to Wednesday webinar. Today's webinar is on the HPG axis in men's health with Dr. Mark Holthaus. My name is Tim Burke and I'm a member of the Dutch Marketing and Education team. I wanted to thank you for taking the time to be with us today. I have a few housekeeping items before I introduce Dr. Holthaus. We have a great opportunity for all new providers to try out our Dutch test for 50% off up to 5 test kits. This includes free clinical consults, tutorial videos, and patient referrals. It's really simple to sign up. Just click on the link that I posted in the chat and become a provider form, fill out the Become a Provider form on the website. After you complete the form, someone from our team will set up a one-on-one appointment to help you answer any questions and walk you through our onboarding process. For more information about Dutch testing, our webinars, you can contact us at sales@dutchtest.com or call 503-687-2050. That's 503-687-2050. I've added the slides to the handout section so you can download them now if you wish. We will answer as many questions as we can at the end of the webinar. You can submit your questions in the questions section on the side panel or on your screen throughout the webinar, and I will choose a few for Dr. Holthaus to answer at the end. Also, we will send out the webinar replay and the link to the presentation slides tomorrow after we're all done. If you're not familiar with Precision Analytical and the Dutch test, Dutch stands for Dry Urine Testing for Comprehensive Hormones. Our validated 24-hour 4-spot dried urine test provides a complete evaluation of sex and adrenal hormones, including metabolites for both baseline hormone testing and effective hormone replacement therapy monitoring. We offer simple and convenient at-home collection for patients and an easy dropship option for providers. Our advanced testing methods help providers answer the most complex clinical questions with the most reliable and trusted results. In addition, our customer service team and in-house clinician consulting team will always be available to answer any of your questions. At this time, I'd like to introduce to you Dr. Mark Holthaus, our presenter today. Dr. Holthaus received his graduate degree in biology and then attended Loma Linda University School of Medicine. He did his residency training through USAF scholarship program at UC Davis Medical Center in Sacramento, California. Dr. Holthaus began studying integrative medicine practices, then became certified by the American Board of Holistic and Integrative Medicine at Scripps in San Diego, California. He was in the first cohort of certification in functional medicine through the Institute of Functional Medicine and teaches with the Advanced Practice Hormone Modules team. He is also a fellow of the American Board of Integrative Medicine, American Board of Physician Specialists, and was appointed Assistant Professor of Family Medicine at Loma Linda University School of Medicine in 2013, where he continues to teach preventative cardiometabolic medicine. Currently, Dr. Holthaus is the Acting Medical Director for Functional Medicine of Nevada and Functional Medicine of Idaho. So without further ado, please join me in welcoming Dr. Mark Holthaus.
Thank you, Tim. Thank you, Winter. And thank you, Mark Newman at Precision Analytica for the opportunity. This is always a great audience. You guys are so engaged. It's a topic I love because it's often ignored largely. We spend, and I even spend a lot of time with women's health and hormones. And so it's great that we can actually take some time to really focus on the guys' side of things. We always refer to the women as kind of the Ferrari, the fine tuning, and the guys are more the Ford Mustang, you know, a little bit more basic, but there's still some finesse to be had. A little bit, just because we've got a short amount of time on basics, and then we're going to just move right through. We want to talk about just the basic physiology. As you guys know, there's this brain central control from the hypothalamus that's releasing gonadotropin hormones, releasing hormones, telling the pituitary, giving it its marching orders basically to via FSH and LH to either make sperm cells and sperm or androgens via the Sertoli and Leydig cells there. What you may not know is that over the recent years, there's been this kind of grand central station protein complex in the hypothalamus called the kisspeptin hypothalamic complex that receives a lot of data from the outside body, and things like leptin, cytokines, and some others that we're discovering all the time. This is where they largely are docking and acting as ligands. And we know that most of us guys start off with about 700 million of these Leydig cells in the testes initially, and we lose about 6 million of those a year starting at about age 20. So there is this primary form of testosterone deficiency that begins right away. Some of the ways that testosterone is carried around in the body, about 60% of it is tightly and what we like to say in the business, fairly irreversibly bound to sex hormone binding globulin, this lowly liver synthesized protein. Roughly 38–40% of it to albumin, which is part of the bioavailable. It's not irreversibly bound. And then only 2% of it's actually free, which is where the heavy lifting is usually coming from. Remembering that testosterone gets metabolized, and it gets metabolized downstream to things in the 5-alpha reduction process to 5-alpha DHT, which is the most androgenic of the androgens. That binds to the androgen receptors in addition to T itself. We also know that you've got significant aromatization that's going to be occurring and taking it down to estradiol, and estrogen has its respective receptors as well. So remembering where the T goes is pretty basic to going where we're going today. So what does it do? Well, we all kind of know from our basic training that it's a tissue and growth repair function. It's involved with male reproductive health, sexual health. Some of the things that are more novel that you might not have heard about are testosterone's role as a biomarker of other diseases, things like COPD and asthma and autoimmune disease, consumptive diseases, chronic illnesses. In addition, adipocyte growth inhibition, in other words, not having enough testosterone can sometimes lead to really less desirable problems there on body comp. And body composition is intimately connected to testosterone. We know it's involved with energy metabolism and cardiometabolic diseases. Figuring out those associations is where everyone's racing to try to figure that out. And how is it causation? Is it just an association? Is it just a marker for other comorbid disease? And yes, it's involved with lipid and cardiovascular medicine directly. Some of the things you guys know about musculoskeletally, these are papers that are talking about how testosterone is needed along with other hormones that are instrumental in not just developing primary, but later secondary sex characteristics. And when we're low in testosterone, it can affect either of these areas. We know obviously that it's important for libido in males and females, as well as erectile dysfunction. We know that there is a kind of this dogma that it goes away as we get older. I will tell you that this connection is probably less tight of a connection than we once thought. There are a lot of guys in their 80s that maintain really good levels of testosterone. And it appears in the literature that testosterone deficiency that occurs with age seems to be something that's more tightly, more statistically connected to comorbid disease than it is age by itself. So what is low T? We've gone through some taxonomy and some definition changes in the recent years. We like to call it TD, testosterone deficiency, not hypogonadism anymore, because it's a little bit more specific. When it comes to replacing testosterone, a lot of us still say TRT. There's some more recent publications that refer to testosterone therapy as TT. So those I'll be using kind of interchangeably. Know that it is a real deal. I mean, these are from Mayo Clinic proceedings in 2016, where they're identifying it as a real problem with quality of life that can affect organs when we're low. It's also largely defined, though, on how we define testosterone deficiency, and that's where some of the confusion has really come about in some of our larger community-based trials. We know that it's something that you want to check and then recheck if it's abnormal on a separate occasion, because a lot of times you'll find that it's not reproducible. Somebody who had a bad day, they were malnourished, they were under some intense stress that led to a transient decrease. And it involves this sex hormone binding globulin. You got to know where that's at too, to know if you can take this total testosterone at face value when you're looking at it. And for those of you who don't know about what drives abnormal sex hormone binding globulin, we'll get into a little bit of that, but it's going to be crucial that you know that, so that you know when it's important or really mandated to know a free testosterone level as well as a total. The diagnosis is really putting a clinical picture, the physical exam, signs and symptoms together with an abnormal lab. There really are no single studies that have been shown to have a eugonadal threshold above or below which you can distinguish guys that have testosterone deficiency or not based on signs and symptoms, including sexual signs and symptoms. And this is what we've had to grapple with in the research in this area. The American Urological Association has said as well, there's really no eugonadal state that we can clearly define as we can in some areas in science like cholesterol. So the etiologies, well, we've got this traditional way we've all kind of learned it. Primary testosterone deficiency or hypogonadism, as we learned it, usually you've got this low T associated with a exaggerated response coming from the brain, realizing, hey, what's going on downstream? You guys aren't paying attention to the message. Secondary, on the other hand, having either a low or inappropriately normal gonadotrope response tied to a low T, being a problem from the brain, not so much the end organ. And then a newer category, some of you might not be as familiar with, is the mixed testosterone group, where they've got origins of etiologies coming from both the gonad deficiency or the brain message not being there. And you'll see low T with kind of a mixed bag of FSH and LH levels in these folks. So here, very simple diagram. Secondary, it's a brain message signaling problem. Primary, it is a gonadal hyporesponsiveness. The symptoms of low T are really divided up in my mind as those that are really well supported, that are very specific in the literature to low T, and those that are more soft, that are overlapping with many other conditions, such as problems with depression and things like that. We know that low T often is associated with belly fat and central obesity, bone loss, a lack of energy, drive, zest for life. We talk about indecision and depressed moods and brain fog. Some of the things that are a little bit more specific have to do more with loss of spontaneous AM erections, libido, erectile dysfunction. So low T signs and symptoms, it's very likely that you're going to come across variable reference ranges depending on the labs that you're using. These are some general guidelines that this Mayo Clinic Proceedings paper published, which I thought was kind of interesting. You're going to start to, in general, see decreased libido when you get into those low 400s, nanograms per deciliter, we're talking. A lot of the papers are published in nanomoles per liter, and so make sure you've got your units straight when you're comparing. Increased visceral fat, you're starting to see that usually in the mid 300s. Mood and depression issues in particular, and also insulin resistance syndromes start creeping in the high 200s. And erectile dysfunction often isn't showing up till you're getting clear down into the low 200s nanograms per deciliter on T. And these are rough guidelines. I've seen guys in 400 and 500 having ED because it's a multi-mechanistic issue with a whole bunch of causes, testosterone deficiency often just being part of it. So when we talk about low T in young men, we're really looking at how things can masquerade. a lot of things symptomatically. People present with all kinds of things. ED is often the one that they show up with, or their wife comes in, or their girlfriend, they're complaining of these problems. We're thinking automatically, it's due to low T, when in fact, you pull off the mask and you find out, asking deeper dive questions, that really this is a person who's just undergone incredible amounts of stress lately. And we know acute or chronic stress can affect testosterone levels right away. And that's one of the reasons why we do a verifying lab at a separate time. Lab assessments in young men in general, we're looking again for that primary and secondary distinction to figure out what we're going to need to be doing, looking at gonadotrope levels in addition to serum total T. From most of us that are doing this, and I'll tell you why I do serum as we go into this. There is growing evidence that there's this kind of secular age-independent decline in testosterone in general in men, especially in Northern European and developed countries. There's a lot of controversy on this, stating that there's methodologic problems in the way this data was gathered. It kind of parallels the data that in the last 40 years showing increased male factor infertility and problems with sperm counts. The arguments are raging on both sides. There's zealots on both sides. I tend to believe that, yes, this is real data. We need better quality studies, certainly, to validate, but this is a paper that's saying, hey, maybe testosterones are declining independent of age worldwide as a problem. I'm certainly seeing more of it in my own practice, but I'm also biased. I'm getting people that are coming for that, and I'm very attuned to searching for it. So what are some of the etiologies that we think are at some of the root cause of low T? Well, we know that hypothyroidism can lead to a form of secondary testosterone deficiency. TBIs are a big issue, and you can see up to 40% within 6 months of a TBI still having low total testosterone. So that's one that needs to be kept in mind, especially with your younger men that are playing sports. Zinc deficiencies, often overlooked. People that have problems with achlorhydria or less than adequate absorption, either with hydrochloric acid or other things in the small bowel, upper bowel, where zinc and other cations are being absorbed or not. Zinc deficiency is a huge association with testosterone deficiency as well. Excess alcohol, excess drug use, the whole argument of cannabis and endocannabinoids with what it does to androgens is very controversial. It's fairly clear that there is some disruption with sperm and endocannabinoids. What's less than clear is what's going on with THC itself and marijuana smoking. The removal of a testicle, obviously, environmental toxins. We're going to talk about those in more detail. Obesity, sleep, stress issues, and certainly medications. We know about anabolic steroids. Some of you might know about pain meds, but there's some other things like the old tricyclic antidepressants and H2 blockers that have a role as well. As far as toxins are concerned in the environment, we know in women, young boys, and in men that phthalates are a big problem, whether they're low or high molecular weight. These are throughout our society. People are exposed to these all over the place. And we know that in women, age 40 to 60, boys in this study, 6 to 12, and in men, ages 40 to 60, there were significant decreases associated with phthalate exposures in urinary metabolite measurements. Other things besides the environment that are suspected as having a role here certainly is obesity. Lots of data. This happens to be one on adolescent boys, teenage boys, 50% less T over their lean cohorts with non-obesity. And this is something that we're seeing leading to earlier and earlier subfertility and impotency problems in young men, even in their early 20s now. And I'm appalled at how much of that I'm seeing actually in young men. Stress and sleep deprivation is not to be overlooked. I mean, there's psychosocial stress, there's sleep deprivation, both acute and chronic, that we know affect T levels. This is a paper looking at male internal med residents compared to other age-matched cohorts in the hospital that were working, and showed a significantly decreased prevalence of low T. Psychosocial stressors, same thing. And that's when you're controlling for things like BMI, central obesity, tobacco use, alcohol consumption independently. We know that in just 5 days, we can see with physical and psychosocial stress in men, huge increases in free urinary cortisol, also in plasma cortisol, but a concomitant decrease in serum and plasma testosterone levels as well. We think that it works via this gonadotropin inhibiting hormone in the hypothalamus, and this puts a kibosh on the message going to the pituitary. Sleep loss, big deal, even after just, a few nights, a week of 5 hours or less. Man, I'm glad I didn't know some of the stuff in residency, right? This is like the 1-2 punch for med students here. You get 10 to 15% drop in testosterone. This is a JAMA paper from 2011. Medications themselves, opiates are a big issue, and there's meta-analysis showing this. This is a mechanistic slide showing that we think it inhibits at the level of, again, gonadotropin releasing hormones. It seems to be dose dependent. So your guys that are on, Norco and Vicodin and chronic pain management, definitely you should be evaluating them for low T, especially if they're exhibiting signs of depression, mood, or bodily signs. This is a slide provided me that was looking at tramadol's effect on the Dutch results of testosterone, and showing how you can get this suppression of many of the sex steroids, not just in testosterone, that can be associated with chronic pain meds. Male patients, everything can be shut down, but in particular, talking about androgens today. And where I've seen the biggest impact personally has been certainly on total testosterone in the serum and urinary conjugates of T on the Dutch test. Other less common causes that you might want to just keep in mind, certainly radiation, any kind of chemo treatment, disruption of blood supply, infarctions, storage diseases, hemochromatosis, things like this, trauma, as things that you do not want to miss. That high prolactin level, checking an MRI of the sella, don't forget to do that. Are they common? No, but when you see guys with a total serum T that are tanked sub 200 nanograms per deciliter, be thinking of prolactinomas and microadenomas. Lifestyle is everything for this discussion, and the more and more that we have better quality studies starting to come out away from just observational trials and more clinical trials, we're seeing that the association between lifestyle and testosterone deficiency is absolutely huge, and actually that more of our clients likely are going to respond to lifestyle and not need testosterone replacement therapy. Food is huge. Micronutrients are big, and everyone asks me, hey, what's the healthy prostate diet? What's the healthy T diet? It's the mitochondrial support diet, right? It's things that are brightly colored and antioxidative, that are low glycemic, that are going to contribute to stimulating muscle mass. So getting adequate protein digestion, things that are low glycemic and not going to promote visceral adiposity. We know that not only is stress and cortisol kind of the kryptonite to testosterone, but so is insulin. The higher the insulin levels are when you become insulin resistant, your testosterone definitely goes south. If we compare exercise, going on our talk on lifestyle here, this is a study looking at 90 abdominally obese Asian men in this particular trial who are on a dietary program coupled with exercise, no big surprise. The people that were doing more of the moderate intensity aerobic exercise in this particular paper had better sexual function, better androgen levels, and body composition than those who exercised less than 150 minutes per week. And it's true in both young and old men, and it's true with resistance exercise that we'll see better levels of androgens in this particular paper, free testosterone associated with resistance training. The truth be told, we need both types of exercise. HIIT, the Tabata drills, the high intensity stuff with aerobics, we know kind of does a great job at basal testosterone levels maintenance. And we see that resistance training has a huge impact on upregulating androgen receptor density in the skeletal muscles and improving testosterone to cortisol ratios above and beyond even what you get with aerobics. So you really need all those different types of exercise to maximize T. Mitochondrial support's huge, and these are just some of the things that I use to support in the nutraceutical and micronutrient discussion my mitochondrial function. This is one of those I put in a laminate and keep in my exam room and use as a teaching point in the exam room with patients. And a continuation, this is again looking at more of the micronutrient side. Zinc and mag, vitamin D are huge with testosterone involved with actually synthesis. B complex is everything mitochondrial, as you guys know. Because testosterone is so dependent on the antioxidative properties of these micronutrients in the testis itself to protect itself from things like cadmium and oxidative stressors. It's important to have a lot of these antioxidant micronutrients around, including A, C, E, selenium, and the minerals listed there. This is a study just showing that there's a lot of folks that have infertility associated with low T, and often by correcting the zinc, you'll correct not only the testosterone levels, but their sperm count levels will raise, and not in a big old long drawn out thing. This is just 6 weeks of therapy, 60 milligrams in this paper, looking at that. We know also that the male reproductive tract is a target organ for D, and there's a plethora of studies looking at optimized D being associated with optimized forms of testosterone, both total, bioactive, and free. This paper looked at 3,000 IUs a day compared to a placebo for a 12-month period with significant improvement in all forms of testosterone. We know, as I alluded to, that antioxidant mechanisms, this is looking at superoxide dismutase and glutathione peroxidase in particular, are affected with things like cadmium and other heavy metals that are promoting oxidative stress in the testicular tissue themselves. This paper was a study in birds, actually, looking at pre-dosing with selenium could really be protective from some of these pro-oxidative effects of environmental heavy metals when supplemented versus not. Human studies, we've got very little in this arena on that, but makes sense to do those when we can. So we've talked about vitamins, micronutrients. Let's talk about some of the other options to helping testosterone besides jumping right into TRT. Especially with younger men, we start with a lot of botanicals first. We'll look at lifestyle. We get into some of the RX stuff that are sparing of testosterone with HCG injections and clomiphene citrate. Botanicals, we hear all kinds of things about Tribulus terrestris and maca. There's other new kids on the block for some of you: fenugreek, blackseed, ashwagandha, mucuna, longjack. The data in this Cochrane PubMed review, did a systematic review over a 16-year period, was pretty enlightening, and so I thought I'd share that with you guys. There's a lot to do about Tribulus and maca with raising T, when in fact there's not a lot of data that those things improve androgens as much as they're involved maybe with quality of sperm. Instead, in this review, there were pretty good evidence that things like long jack, mucuna, ashwa, fenugreek, black seed, and some of these botanicals actually were very helpful in not only raising T, but helping with improved sperm parameters, which is also a big deal. And we're not talking, again, a long period of time. We're talking about 12 weeks, somewhere around 5,000 milligrams a day of this powdered root extract of either ashwagandha or, in this particular case, mucuna, getting these benefits. As far as prostate health, saw palmetto is up and down depending on which JAMA review you read. You know, the first ones that came out were very positive. The more recent ones, they're larger, double-blinded, randomized trials show that it really doesn't separate itself out for prostate BPH above and beyond placebo, unless you start seeing it in combination studies with things like pygeum and nettle roots and ryegrass pollens, things like that. This is a paper showing that if you add things like onions, garlic, tomato, in addition to some of these other herbs and botanicals, you can see some preventive and supportive areas in the prostate itself. This is just further data on the mucuna and ashwagandha 12-week period, raising testosterone serum total levels to 100 by 151 and 140 nanograms per deciliter over just 3 months, respectively. Pretty impressive numbers. And this is just a summary slide of what we just talked about. So what do we do with young guys that are low in T that want to preserve their fertility? This is a common presentation that we get. We know that testosterone is required and really for maintenance of established spermatogenesis, but also for restoring it if something messes it up. FSH is necessary to kind of fully develop the testicle tissue-wise. It's not just for sperm maturation, and you need really both an FSH and an LH presence to get total testicular development and maximum sperm counts. So either alone will raise sperm counts, but you need both together to get the full deal going. We know that FSH at about 150 IUs and about 1,500 IUs of LH, or its beta, its synthetic analog of the beta subunit of LH, we call HCG, is necessary around 3 times a week sub-Q to initiate and maintain spermatogenesis. T levels will rise if you give HCG, LH alone, but you need both FSH and the luteinizing effect, LH effect, to get to that maximum number of sperm counts. So those of you that think we can just give testo and an FSH, you're just never going to quite get there. You need both FSH and LH for fertility. Medical interventions really are centering around the two non-testosterone options of HCG and Clomid, and then of course TRT. We kind of save that more for the older guys, and we start with other things with the younger men. So the guarantee is that when you do testosterone replacement, you're going to see testicular atrophy. Usually goes away when they quit taking it, but for a lot of younger men, this is a no-go. It also acts as a birth control, right? Because you're getting central suppression and negative feedback, so you're not going to be getting FSH, you're not going to be making sperm. So if you're looking for fertility, you just can't use TRT. It's going to suppress things centrally. The sparing options, you've got to have a form of secondary testosterone deficiency to be able to use Clomid or HCG. They are both reliant on basically the messenger side of things, and filling that void, they've got to have a normal functioning gonad. So you're not going to see necessarily as much aromatization and production of estrogen, nor the atrophy of the testicle using those testosterone sparing options. Again, HCG is this luteinizing hormone. It's an analog of the beta subunit of LH. Clomiphene citrate is actually FDA approved for guys that need to stimulate that sperm production and get things rolling that way, who have low sperm counts. It's off-label as an androgen stimulating, but we use it that way all the time. Remember, it's a selective estrogen receptor modulator, so it blocks the negative feedback at the hypothalamus of estrogen with a subsequent surge of FSH and LH, and that's how that works. Again, HCG is really just acting as a synthetic gonadotrope, and LH stimulating the Leydig cell to make more T. You can give these things as pulsed doses. Some people will use HCG injections anywhere from 1,200 to 3,000 IUs, divided evenly over the week. You can do that for 2-3 months, followed by a month off, a holiday. It's effective with or without testosterone. It's available as a sublingual as well. I've not done that, but I've seen folks that are getting that. It's a little harder to know how to track that when they're taking that sublingual following. It's also a little bit more expensive. You do, when you give these testosterone sparing options, still need to follow things like their rectal exam and ask them about lower urinary tract obstructive symptoms, PSAs, liver, bone marrow, just as if you're giving testosterone, assuming that you're going to get a bump in T. Don't forget. Citations for that, Clomiphene being the one, it's kind of my go-to with younger guys. I used to start with a loading dose of 50 milligrams, one a day or one every other day. And honestly, I get more side effects doing that. So I usually now start with 25 milligrams, one a day or 3 days a week, as is written here, to avoid guys feeling more emotional, tearful. They don't feel good. They sometimes retain a little bit of fluid if you give them too much. And there's just no reason to ramp that up aggressively. It's often done with drug holidays. It's not something you have to have them taking every day. Some of these guys will take it 5 days out of 7 and take the weekends off. Remember how it works. We talked about that already. So the advantages with Clomid is that you don't get the central LH FSH suppression. You don't get that with HCG as well. It maintains fertility while correcting the low T. It is less expensive than HCG, and I find that most guys it's an easier ask for them. Some of the disadvantages, there are some issues with GI side effects. They talk about hair loss, minimal weight gain. I haven't seen any of those things. I have seen a little bit of gynecomastia transiently when I used the 50 milligram level and some water retention. I've not seen any kind of visual disturbances. If they do complain of that, just stop the drug. It goes away as soon as that occurs. I'm not sure of the mechanism behind that, but again, I've not seen that. This is just a before and after looking at serum T increased from 325 to 881 on a loading dose in this particular example of Clomid, both before and after, and you can see the downstream metabolites and the androgens all responding in unison there. So it's a great option to try, especially in your younger guys. So what do we do about T and aging? What do we know about that? We know that in a lot of guys after about age 25, there's a decrease is fairly predictable, somewhere between 0.3 and 1.5% per year. As you get older, that velocity rate of change can pick up a little bit. There's this concomitant decrease of T going on with a rise in SHBG. So as you age, you get kind of this 1-2 punch on losing testosterone. And it's about a 1.3% increase in SHBG that's beginning per year, about the same time, mid-20s, early 30s. We see a greater decrease in the bioavailable or free portion of testosterone as men age, because you're getting that bump in SHBG, which is binding up more and more of the testosterone, leaving less for free. So you'll see a concomitant decrease of free T that's a little bit more rapid per year occurring. The prevalence of testosterone deficiency is all over the map. This is studies showing in the US how from 6 to 30%, big range. It really is dependent on how you define it. You know, are you looking at testosterone as a total serum? Are you looking at the calculated free T? Are you looking at all comers with abnormal labs, or people that also have signs and symptoms? Are they sexual signs and symptoms? And as you put more filters on, the prevalence of testosterone deficiency varies rapidly. This trial looked at including both total and free being low, in addition to having decreased libido, AM erections, and ED as well. And when you put those three sexual signs on with meeting both low, total, and free, it went from 23% to a prevalence of as low as 2%. We know that there's different prevalences by ethnicity, which was published in this paper showing with Asian males and then in Australia. Key points is that it's common. You know, age is not as probably a bigger risk factor as we once thought. It's probably more tightly associated with the comorbid diseases that guys get as they age than the birthdays themselves, which explains why most of the testosterone deficiency we see are secondary. About 85% of all comers are secondary testosterone deficient patients with comorbid diseases, and that the tightest correlation is seen in these large community-based trials between age and primary testosterone deficiency, more of a Leydig cell failure, gonadal failure. So don't assume every old guy needs it, but also don't assume that some of these young guys may not have testosterone deficiency that's pretty significant, especially with the obesity epidemic we're living in. So saliva, outside of testosterone being checked in the serum, now we're moving on to other options. Saliva and blood spot testing, both things that I did when I first started practicing men's health and women's health. I tend not to use these anymore simply because of my experience not finding that they were a reliable and reproducible way to follow and manage testosterone deficiency. You know, often there's a little bit more cost involved as well, and there's more studies involved with serum. There are studies that try to correlate tissue levels in saliva. I'm just underwhelmed by how robust those are. They're not compelling to me when I look at what we've got on serum and dried urine. The free androgen index is something some of you have been just, you know, what is the actual free T? We've got pretty good calculation methods to get at free T now, and so the Endocrine Society and most of us just have, this has by attrition fallen out of favor. It doesn't have good data showing that it predicts free T or bioavailable T. So I don't use a free androgen index. That's basically the total T divided by SHBG and a fudge factor to get that, but pretty obsolete. Serum T, I use this. You know, it's got the most data. It's covered by insurance. Yes, there's this ridiculous range because we don't know the range of eugonadism. And that's why we can't rely just on the lab. We've got to rely on signs, symptoms, physical findings. You want to check sometime fasting, about 8 hours since the last meal, preferably at least a day, 24 hours since the last sexual activity or major stressor. You know, if somebody's been sick or acutely ill on meds that are known to decrease T, you shouldn't be checking it. It's most important to do it in the morning between 7 and 10 a.m. with younger guys under 45, where there's this huge diurnal variation, which goes away as men age. There can be as much as a 20 to 50% difference in T levels in the serum between morning and afternoon in guys under age 45. The first step is to get that initial abnormal and then to confirm it on a separate day. When I do that second confirmational lab, always am going to be looking at other labs to figure out, is this primary, is it secondary, what's their PSA, you know, is it going to be safe to give to them, their CBC, are they already having problems with erythrocytosis or liver inflammation? I need to know those things. So I'm looking also at downstream metabolites like estradiol and DHT. Sex hormone binding globulin is really important to understand, as I mentioned, because if your total testosterone is near the border, low normal, and you have a really elevated SHBG, which is seen in things like chronic liver diseases, people that have got a lot of aromatization, a lot of endogenous estrogen going around, people that are on low protein, low fat diets tend to have elevated SHBG levels, or just guys that are older have higher SHBG. It's really not safe to assume that you can take that total testosterone at face value in those kinds of conditions. So make sure that you check an SHBG and a free testosterone if you're going to be confirming that after an initial low total serum T. And so, yeah, this is just talking about knowing that you need to look at other labs. If you've got an initial total T that's low, prolactin is one of the things I'm probably going to be checking to know if I need to look at an MRI for a prolactinoma. Know that prolactinemia is rare in men as a source of low T, but be thinking of it when you see guys that have levels lower than 200 nanograms per deciliter with a total serum testosterone. That's going to be more likely. Alternate lab options. Okay, so yeah, we've gone through this. Making sure that you've got a baseline PSA, I think, is important, especially in guys over age 40 that are higher risk. The whole discussion of prostate cancer and testosterone, we've got a dedicated section coming up on. This is my panel that I do when I'm doing that second confirmatory test, so I have those answers that I need as to the safety of being able to use T if I'm going to do TRT. Some of the trends that occur with aging, we know that, as I mentioned, at around 30, you're going to start seeing things like in guys, pregnenolone and testosterone, DHEA, going south. Around age 50, progesterone starts going south as estrogen levels are coming up relatively. We see increases with age with sex hormone binding globulin, PSAs, prostate volumes, prolactin, the gonadotropes themselves, as well as the estrogen. Estrogen dominance, guys get this too, and it's more of a problem in the prostate tissue because of some of the etiologic concerns we have with prostate cancer. Its association with things like estradiol and dihydrotestosterone as an active T metabolite. Know that it's more of an issue with the T and the progesterone declining with age than it is an absolute elevation of estradiol in men that sets them up for estrogen dominance. We look at what upregulates aromatase, and this is the thing you want to really pay attention to before you start having somebody starting injecting or putting pellets in them. You know, if they're excessively drinking, if they've got a lot of inflammation, a lot of stress, if they've got excess leptins. I always check leptin and fasting insulins for this reason. You know, not only are they going to have issues with cholesterol and lipid physiology, but they're potentially going to be shunting a lot of their T to estradiol. So looking at those cardiometabolic, stress, inflammatory, and even micronutrient connections like zinc deficiency are important with aromatase. Leptin and insulin are a big deal with excess estrogen. The diagnosis we talked about needs to be the lab coupled with signs and symptoms and physical exam. You don't want to interpret testosterone deficiency in a bubble looking just at the laboratory by itself. Some of the root cause things that we want to be looking at, of course, are the hypothyroidism, which we talked about. Some of these things with environmental exposures, lifestyle choices, but zinc deficiency, stress, medications we talked about. The one that's novel on this list, lipopolysaccharide translocation. We know that obese men have more gut permeability, more leaky gut. And so there is more LPS, and LPS spawns basically TNF alpha, IL-1 beta, IL-6, and those inflammatory cytokines directly inhibit at the level of the testes and at the hypothalamus the production of testosterone. So that's following the bouncing ball of leaky gut, not just with non-alcoholic fatty liver disease, but now we know it directly impacts testosterone production, as it does progesterone. So thinking of your estrogen dominant females, your PCOS females, right there with leaky gut and your guys with leaky gut with low T. Hormones are affected by what's going on there. And then some of these other things we've already talked about. We know that age obviously is a factor. There's a huge association with the amount of type 2 diabetes, central obesity, of course, elevating SHPG with age. All of these things go up with age, and so not to be confused as a causation, but an associative comorbid that is going hand in hand with low T as we age. That's the big question: is this a marker for these comorbidities, or is there actually an etiologic causation? And a big study came out January of 2021 in Australia, showing a group of men that were low in T that had prediabetes and type 2 diabetes, and the ones that were on testosterone replacement and brought back to normal had far less diabetes at the end of the study. And so we're getting some more data in showing some cause and effect, but that's going to take large numbers. You know, we're talking about trials upwards of 17,000 men to get that kind of statistical power on not only efficacy, but on safety. We know that it's common. We know that regardless of age is something you need to be looking at. It's not just a lab. Look at the guy in front of you. It's an issue with comorbidities more than it is probably age, especially when we're talking about adult onset hypogonadism, or what is 85% of what we're seeing walk in the clinic, a garden variety secondary testosterone deficiency. And most of those, 89% of those secondaries, have no known obvious cause. You know, so it was great that we learned about these categories. This is the Mayo Clinic proceedings showing primary, secondary, and normal eugonadal, and now this compensated group. But if you look at these distributions by gonadal status with decade bands, it's the compensated and primary group that seem to correlate with age and TD, not so much in the secondary hypogonadal group. And those are the people you're going to see. 85% of your all comers with low T are going to have secondary hypogonadism. So comorbidities and TD. Inflammation is a big deal, and the area goes both ways. More inflammation, less testosterone, more inflammation. We know that there are things that comorbidity-wise that seem clearly to be improved by optimizing T, things that are less clear, and things that we're really not sure about at all. And some of the things we're more clear about, with inflammation being one of those, we know that both estrogen and testosterone have effects. They actually have receptors for these sex steroid hormones on these white cells and immune cells. And not only that, they directly regulate cytokine genetic expression, both pro and anti-inflammatory. So the sex steroid hormones have a role in both the cellular and the cytokine parts of our immune system. Low T is associated with an increase in inflammation. TRT, when we normalize it, seems to be associated with a decrease in inflammation. And it's not just CRP, it's these other guys that we talk about all the time: TNF alpha, IL-1 beta, and IL-6. And that's independent of the lipopolysaccharide leaky gut deal. This happens in addition to that. These are basically some of the inflammatory phenotypes that get expressed that we spend an inordinate amount of our clinical time on each day in our offices. Metabolic dysregulations, certainly cardiovascular disease, autoimmune diseases. These are some of the AI diseases now that have a very tight link with testosterone deficiencies. Again, the prevalences of low T associated with comorbid diseases are very high. That's the take home there. If, like diabetes, saying it's 50%, are going to have low T. If you control for BMI, things like COPD and other chronic diseases, chronic kidney diseases, those associated links decrease a little bit. But no matter who you read, there's a prevalence of about 30 to 40, 50% of type 2 diabetes having low testosterone. So these are not uncommon associations. We know that there's problems with decreased libido and erectile dysfunction that are certainly improved by optimizing T in addition to the inflammation story. This is a paper that was published looking at male libido. We've got patients, great stories looking at erectile dysfunction and libido on optimizing T. The literature is replete with that. What's interesting is that a lot of folks, if you noticed on that earlier prevalence side, only about 19% of guys with erectile dysfunction have low T, which is funny, right? That's why most of them come in to see us. But they're going to be much more likely to have a problem, a prevalence association with having one of the cardiometabolic things like obesity, diabetes, or dyslipidemia. And this is partly why, and this paper describes, that nitric oxide pathway is critical for initiating, maintaining an erection. We know that in the corpora cavernosa that the nitric oxide synthase is regulated by androgens, and in this particular study, which is a rodent study, with castrated animals, if you provide testosterone, the nitric oxide synthase protein expression kicks up and you can restore erectile function. So with ED, it's about combining and optimizing testosterone, optimizing that itself, in addition to PDE5 inhibitors, paying attention to the cyclic AMP, the Viagra story. You often need both to get things to work, especially with diabetic men. So don't give up. There's probably something more they need if testosterone doesn't fix that. Other comorbidities that we know are improved by TRT. While low muscle mass and certainly low bone density are classically in the literature supported, this being a 400 male trial looking at just that with increased muscle strength, bone mass with optimizing of T. And it's not just muscle mass, but it's strength that is improved with optimizing T. Building muscle mass, bone density, while reducing abdominal central obesity, well established in the literature, assuming there's good growth hormone levels. A word about growth hormone. We didn't have a lot of time to really go into this in this talk, but it is very different. IGF-1, insulin growth factor 1, is not the same thing as growth hormone. These get confused often by clinicians. They have very unique roles in the different tissues. Some are highly correlated with cancers. And so we've got to be really careful with our guys that are taking this kind of under the radar and have not had documented low growth hormone levels. There's just not a lot of data that shows they do better with body composition or in any way above people that are doing lifestyle. In addition, we know that it's involved with fat reduction and lipolysis along with testosterone. It's involved along with testosterone with collagen and optimizing bone and muscle that way. Some CIMT studies on observational trials have shown less atherosclerosis in the carotid intimal medial thickness with not only growth hormone, but also with optimizing T. It's associated, as is testosterone, with more favorable lipid panels and profiles. Restoring T, this is a small trial, but it is double-blinded, showing that TRT improved fat-free mass, lean, and also functional capacities. This is a study from the Journal of Clinical Endocrinology that showed, compared to guys placebo, if they were given a testosterone gel starting out with low T, that they had less visceral fat and more lean muscle. T is a bone builder for sure. Even the testosterone trials, which were released here in 2017, large study, randomized clinical trial showing that optimized T was associated with not only better bone mineral density, but estimated strength of the bone, and that was at both spine and hip for data. Testosterone is great at preventing sarcopenia as well as building bone. This is an older study showing that skeletal muscle protein synthesis and improved lumbar bone mass in the lumbar spine with elderly men, improved by optimizing T, with this references there. Other things that we know are improved by optimizing T, certainly beyond just fat, it specifically appears to be central obesity that's improved, which is a big win, with aromatization and excess estrogen inhibiting testosterone with visceral adiposity. We also know that visceral adiposity is an endocrine organ in of itself, just loaded with inflammatory cytokines and activating our renin-angiotensin-aldosterone system, which has all kinds of immune ramifications in addition to cardiovascular. Studies showing that BMIs over 30, 3 times more likely to have testosterone deficiency versus normal weight men in this paper. We think that, you know, chicken or the egg is really kind of irrelevant, because again, the arrow goes both ways, just like with inflammation, obesity, and testosterone deficiency. Well, in obese men, we know that there's now data showing we've got metabolic endotoxemia and gut permeability. This is that whole lipopolysaccharide translocation discussion that occurs, not only decreases the Leydig cell production of T, but also the Sertoli cell spermatogenesis, leading to fertility issues with leaky gut. So now you can add leaky gut with infertility to low T to your lipopolysaccharide discussion. We know that low T impairs insulin signaling. We know that low T increases inflammation. And we know that when you start seeing low testosterone, it can be kind of an early biomarker that a guy is going this way physiologically towards an insulin resistance syndrome. It's bidirectional. It's important that we know that as men age, as they get more estrogen, as SHPG increases, as they get more adipose tissue, we have this reciprocating movement, if you will, towards a metabolic syndrome and pre-diabetic syndrome. It's a vicious cycle, and we as functionalists have a unique opportunity to jump in and disrupt this. And it's involving not just adiposity and waist to hip. It involves mostly all 5 of the diagnostic criteria for metabolic syndrome. This paper showcasing 3 of those. Cardiovascular disease is the one that everyone wants to know about. The evidence does not support increased CVD risk with TRT, period. There's some poorly done studies methodologically that have had a lot of post-publication retractions because, for example, one of the major 2 trials that the 2015 FDA black box warning was based on had women in the control group. They're supposed to be all men. Another one of the papers reported a 50% increase in mortality with CVD treated versus non, when actually it was a 50% decrease in mortality for those treated with low testosterone versus untreated. We've got over 100 studies showing that actually T deficient men have less CVD risk when they're repleted back to normal physiologic levels. This just talking about observational trials. Our biggest challenge in this space is that mostly what we have is cross-sectional cohort observational epidemiologic data. We just don't have a lot of randomized clinical data. And as you guys remember from WHI, we thought estrogen for a while was going to be this great thing for cardiovascular risk reduction. Granted, WHI is a can of worms with progestins confounding things. We don't want to fall into the trap of just relying on observational trials only, telling us that it's safe to give testosterone to promote cardiovascular health. So that's why a lot of us are more reserved. That being said, there are hundreds of studies. The lion's shares of the existing data says that you do better, even older guys, even those at highest risk for MI, repleting and optimizing testosterone when they're low for cardiovascular risk. It improves outcomes. The things that we're not as clear about are cognitive function. We've got studies here representing, improvement. I took Dale Bredesen's course, and I've done lots with the Alzheimer's crowd and Recode and done all of that. And I believe that testosterone in its balance, as with other trophic hormones, is necessary to maintain cognition. We know that there are studies that show there seems to be a higher association of people with testosterone deficiency, men in particular in the data, that have Alzheimer's, and the testosterone deficiency seems to often predate the diagnosis of AD. And here's some of the theoretic ways that we think it probably works to do that. On the contrary, we've got the testosterone trials showing that after a year of giving guys over 65 with clear problems with cognitive function, there was no real improvement in things like visual and spatial memory over placebo giving testosterone gel. So it's an area that's not fully elucidated yet in the literature. Prostate health is the other big area of controversy. Testosterone is reduced to its active form of 5-alpha DHT. We know that it binds to androgen receptors in the prostate. We also know that the prostate's androgen receptors are affected by estradiol levels. There's a potentiation there with estrogen and DHT. Estrogen also inhibits hydrolysis and metabolism of DHT, kind of immortalizes DHT. And so there's a relationship there with prostate enlargement and possibly prostate cancers. There is this whole dichotomy of prostate cancer and low T versus high T. We know that based on some of the things we were taught, as is written here, prostate cancer is an androgen-dependent cancer. The gland is covered with these androgen receptors, and the higher the level of T, the higher the risk. Well, that's not what the more recent data is showing. We're showing that, wow, there seems to be no real correlation with serum total testosterone and prostate cancer biology above a physiologic level. Somewhere in the 200s, there seems to be this saturation above which, no matter what you do with testosterone, replacing it or whatnot, there doesn't seem to be a PSA or a prostatic volume reaction. And it does explain this paradoxical observation that the prostate is exquisitely sensitive to serum T, but it's indifferent to changes at higher levels. The saturation model is why a lot of us feel confident that getting someone up to the physiologic levels is safe, and we just don't see dramatic changes in PSA when you're at 250 nanograms per deciliter or higher when you are repleting people. The thing to watch out for, and what this paper shows, is that if you've got guys that are really low on their testosterone, certainly sub 200 nanograms per deciliter, below this saturation point, expect to see bumps in PSA and maybe even growth symptoms, lower urinary tract symptoms, when you start replacing them as you move towards this physiologic saturation point. You probably won't see as much of an issue if you're starting at higher doses, and that's the saturation model. We know that endogenous T, this is looking at population-based 20 different studies, not a real tight relationship between prostate cancer and serum T levels. We know that a lot of the androgen receptors, the ligands in the prostate tissue, is a microenvironment, and what's happening there is largely not so much an endocrine, but more of an intracrine phenomena of localized control. So the saturation model, the knowledge that we have a more localized locus of control with prostate cancer biology, with androgen stimulation, together with a lot of the data just not showing a cause and effect with repleting guys. That being said, I'm always very cautious you know, what should we do? Should I treat these guys with prostate cancer? Well, I always get a urologist on board to co-manage them. And I make sure that they're in a safe group, a low grade, low stage. Gleason, is going to need to be Gleason grade less than 6, somebody who's not got a high risk of recurrence, somebody who's not had brachytherapy, somebody who's not got any known biochemical resistance and showing PSAs going up after external beam radiation, and certainly not anybody with metastatic disease or positive lymph nodes. These are probably the people you want to avoid. The lower grade, lower risk folks that have been adequately treated for prostate cancer, that have low T and have symptoms, maybe yes, and I do under co-management. So selection of your prostate cancer patient who has low T as a candidate for safe testosterone replacement is where everything is. You don't want to give it to those higher risk guys. Everyone getting these steroids, sex steroids for replacement should have a medical informed consent. Whether it's estrogen, I feel, whether it's DHEA or testosterone. We know that there is a role of estrogen and prostate cancer. I'm not going to get into that very much here. We do know that aromatase is 30-fold higher in its activity in the peripheral prostate lobes, where more cancers are found, and more active in metastatic tissue, ectopic metastatic tissue, than in other tissues. So knowing that estrogen does play a role, not only with itself, but what it does to DHT and its own metabolites, its DNA adjuncts from 4-hydroxyestrone, is really what I want you guys to remember. It's kind of a neat, trivial point to know that prostate does express higher levels of things like 1B1 expression. So you're going to have more of a chance to see these 4-hydroxyestrone metabolites. What do we need to do? We need to watch those metabolites. We need to make sure the methylation is rocking and rolling so that it denatures or inactivates those potential carcinogenic downstream estrogen metabolites. Chronic inflammation has an association with prostate cancer, as does prolactin and upregulating some of the survivability factors that are seen with prostate cancer biology. Again, another topic, another day. Dutch is nice because it gives you not only a picture of the testosterone and estradiol and the total DHEA, all the androgens, all 3 of the DHEAs, but it also gives you the downstream metabolites and the estrogen metabolites to know where you need to focus your energy on methylation. Do you need to focus on, really helping 1A1 on the phase 1 cytochrome P450 guys over the 1B1? Do you need to be focusing on methylation for the 4-hydroxyestrones? And then they give you these organic acids to give you an idea as to what's going on with detox and redox in the mitochondria, and B vitamins and oxidative stress, and the cortisol, all of which we know talks to the sex story. Dutch is a great complement when you need more than just the testosterone itself or the estradiol itself to see the milieu of the patient that you're actually treating, with the references there. Things that we're not sure about with sleep, with TRT improving, there's this connection with apnea. We know that sleep apnea suppresses guys centrally with LH from the hypothalamus when they have bad hypoxia and sleep fragmentation. We know that low T serves as a marker of how severe one's obstructive sleep apnea is. However, you won't always see that correcting low T corrects apnea. And you also don't always see correcting sleep apnea normalizing testosterone levels. So there's a relationship there. It's tied with obesity and BMI as well, but there does seem to also be an independent association with apnea, central suppression of luteinizing hormone and low T, apart from just BMI and age. Testosterone therapy and sleep apnea, that's kind of the story. We talked about that. So this is a little diagram that tries to put some hypothetical mechanistics to if you give testosterone, how you can sometimes exacerbate sleep apnea. Make sure that you've treated the sleep apnea before you start TRT. That's the take-home message with these two slides. Some of the things that experts agree on, it's a global public health problem, testosterone deficiency. It is impacting not just sexual and reproductive, but general quality of life in men. It seems to help if you treat it, whether we know the cause or not, which flies directly in the face of the current FDA guidelines. If you read that verbatim, it says unless you've got a known gonadal or brain problem, you shouldn't be treating it. I have found that not to be consistent even with what the experts are saying in the white papers in the literature. Both young and men and old men can benefit or not. We need a lot more RCT trials to know if it's safe for cardiovascular disease and true efficacy. And there are some things going on. Don't be afraid to use it in certain candidates that have had prostate cancer. There's not a lot of data out there, really no data that connects testosterone replacement therapy with causing prostate cancer. Just not there. Once you've got it, or if it's metastatic, that's a different story. So lifestyle is really everything. You know, before you consider TRT, just as more of a review, these root causes, you've got to go after them. It's sleep, it's exercise, it's stress management. You know, this is looking at hormone changes with 15% loss in BMI, showing that it's fairly profound and it affects in a positive way, not just testosterone, but also LH levels by losing weight. Weight loss is by far and away the biggest leverage we have in improving testosterone, everybody. If you don't remember anything, that is the most important. Happens to be probably our biggest leverage point for hypertension control as well in an integrative society. This is looking at 900 men that were in 3 separate groups, a pre-diabetic group, and they were stratified to either lifestyle intervention, metformin, or placebo. And lo and behold, it was the lifestyle group, even above the metformin group, that had the best improvement in less prevalence of hypogonadism at just 12 months. There was a 46% decrease in testosterone deficiency, showing how lifestyle should never be underestimated. This is a trial just looking at visceral fat quantities and looking at how when you do lifestyle, diet related versus bariatric, you're going to see improvements in either direction with not only testosterone, but inflammatory markers and other cardiometabolic risks. Many studies showing that it really doesn't, we don't care how you lose the weight, that it's the weight that's the most tightly correlated with the improvement in androgen levels. We've got studies that talk about gynoid versus android fat loss. The bottom line is whether you lose brown sub-Q fat in a more of a gynoid distribution, or you're losing abdominal obesity android distribution, you're going to see improvements with androgens, sometimes a little bit more in my experience with certainly losing the android central obesity, which is what that study is showing. Intermittent fasting has become my go-to, whether you use time mimicking or fasting mimicking with Walter Longo's program, or you use the free version, as I call it, time restricted feeding. Just know that there's a huge difference between fasting and chronic calorie restriction. It's the undiet. There's really no one that should not be able to fast, assuming the ones that are contraindicated, that are breastfeeding, or skeletally immature, or pregnant, have an eating disorder, active cancer. Of course, those are people it doesn't make sense to do that on. But there really isn't a food that if they can't eat, that excludes them. I don't care if they don't have any money, any teeth, a whole list of food restrictions. Everyone can do intermittent time restricted fasting. And the beauty of it is it works as well as bariatric surgery to reverse obesity and type 2 diabetes. The inability of most diets to be successful is found in their ability to not improve insulin resistance. And the differences between chronic calorie restriction, what they did in the Biggest Loser show, And what intermittent fasting does is that you are basically restricting some food all the time with the chronic calorie restriction, which just promotes yo-yo dieting, versus restricting all food some of the time, usually about a 16-hour period with an 8-hour feeding window, with the most common protocols that are used in intermittent fasting. But check out Jason Fung, F-U-N-G. He's an MD nephrologist out of Toronto. Check out some of Walter Longo's stuff from USC. The data on longevity and anti-inflammation and cancer biology and stem cells and autophagy and topics well beyond cardiometabolic issues and androgens are staggering. More of this in these references. So who needs TRT as a wrap up? Well, the Endocrine Society says that it should only be in men that have signs and symptoms, as we've been talking, combined with a low lab. You need to confirm the lab. You need to make sure that you can take the total T at face value, as we've said. You should look at other labs when you're confirming it to see if it's primary, secondary, and go after those if they're secondary. And then you want to talk about risk, patient shared decision making. You want to induce secondary sex characteristics, puberty if it hasn't occurred yet, and correct their symptoms low T. That's important. When you start people, make sure you follow up at a year at a minimum to find out if the things symptom-wise that they were having have gotten better. If not, I'm not sure they need to be on it. It's not risk-free. Recommend against it, and I agree with these things, if obviously they're planning near-term fertility, if they've got abnormal PSAs, abnormal prostate exams, problems where they've got polycythemia, hit crits over 48, you don't want to start it. You got to find out what's going on. Why are they hypoxic? Do they have apnea? Do they smoke? And deal with that. Deal with any untreated apnea. Pay attention to high prostate obstructive symptoms and abnormal digital rectal exams first. Any uncontrolled stage 3-4 heart failure, stay away. It's great for earlier on stage heart failure if they're low in T. Anyone who's had an MI or acute cardiovascular event within the last 6 months, contraindicated. And your guys over 65, you really got to have a good heart-to-heart, because if there's any data that's a little suspicious, it's in that demographic of replacement. Again, we just don't have good studies. So, questionnaires, the ones I use, the androgen in aging male, androgen deficiency in aging male, ADAM, the SHIM, which is for erectile assessment, sexual health inventory in males, or in the that's going to be for erectile dysfunction, and the International Prostate Symptom Score for prostate obstructive symptoms. I use those three. There's all these others here for your reference. How do I give it? Well, it's all kinds of options. You know, you've got creams that you can do that are compounded, gels that are compounded or available at regular routine pharmacy, injections, pellets. I don't use oral biolymphatics. I don't use sublinguals. I tend not to use patches or nasal, simply because these are modes of delivery that I've just found very difficult to monitor. Low compliance, lots of issues with dermatologic reactions. So it really comes down to these four. And at the end of the day, you got to go get trained for pellets if you're going to do pellets. It's its own area of expertise. I've got a pellet practice here. It's pretty fun to do, but make sure you go get trained. The pros and the cons of pellets are listed there, but basically you got to go through some training. Once you put the thing in, yeah, there's a risk they can pop out. There's a risk that the dose isn't right, and then you're kind of stuck. You can't do a lot of easy adjustments. The topicals are by far the most popular, and the androgels and the testums of the world, being those that are out there in traditional pharmaceuticals, are certainly popular. Just know that there's a high risk of secondary exposures. Know that you can't go jump in the pool or the shower before 4 hours after you've slapped this on your upper outer arm, because it can affect it. And there is some variability with absorption. Gels probably are absorbed a little bit more consistently than creams. Injections are what I predominantly am using nowadays. I use the cypionate which has about an 8-day half-life. I'm usually dosing this somewhere between 40 and 60 milligrams twice a week, like a Monday, Thursday schedule, to avoid excess bone marrow stimulation with excess hematocrit, libido fluctuations, injection site problems, and over aromatization, which can occur. Gone are the days, I think, of us giving guys 400 milligrams once a month. That's pretty irresponsible. We still have some practitioners that are doing 200 milligrams every other week, or 100 milligrams at once. I think the biweekly is more physiologic. Things to watch out for. This is just a list of symptoms once you're on TRT. Again, put this in a slick, in a laminate, have it in your exam rooms to refer to. That's a great reference. So how do I test for it? Yeah, ask the other Mark. That's what Dutch is all about. But this is a classic example of an aging man, comes in with symptoms of low T, no obvious root causes that we can work on with lifestyle right off the bat, because you're all going to have done that, right? He's got a serum T that's less than 300 nanograms per deciliter. He's got a little bit of a response from the brain. LH is up, which starts you thinking that it might be more primary. He's got normal estrogen, SHPG, and FSH levels. So we've got no Dutch available because of a money issue. We, direct all the lifestyle stuff, of course. He's got these findings, and yet with all the best lifestyle functional medicine has to throw at him, he's still got problems with his levels and symptoms. So he ends up getting put on injections, 50 milligrams twice a week. At 6 weeks, we follow up labs both with serum and Dutch, and this is going to be helpful to kind of see the contrast. So serum, his T comes up now from below 300 to 550. We try to measure when we're doing injectable somewhere mid-dose. So if he's doing an early week and an end of the week, somewhere around Wednesdays, when you're going to want to be checking the serum. Not as important with dried urine as to the timing as it is with serum. We're trying to normalize things, his LH, hopefully without suppressing it, and bring his T and his symptoms into line with serum. The Dutch, what we're really looking for is not a high level, but normalizing estrogens. We're going to have the estrogen metabolites there to know what to do then. We're going to have specifically the 4-hydroxyestrone. We're going to have methylation assessment. We're going to also be able to look at epitestosterone, which is another whole discussion about actual gonadal production of this marker along with T, which is usually about a 1-to-1 ratio. There's some unique enzyme deficiencies with secondary conjugation, unique to especially Asian ethnicity, where using serum testosterone might be appropriate. What's cool is that the Dutch lab will show you when there's a pattern that's maybe suspicious for that abnormality, having that UDP enzyme SNP, and if so, they'll probably recommend confirmation of the testosterone level with a serum. But having those other things like the melatonin, looking at oxidative stress, looking at pyroglutamate and glutathione markers is really helpful when you're looking at the mitochondria as being where these things are all happening, either in the gonad or in the adrenal or where have you. So what about estrogen? Well, we don't want too much, and it's because of these things: gynecomastia, increased cardiovascular risk in guys. So look again at what upregulates aromatase. That's really that slide that you guys should be focusing on. You might need to use an anastrozole, and you can use that either in a pill form, 0.5 milligrams twice a week. Some people put it in the pellets. You can use pellets that way, and then you can monitor their estrogens. I like to keep their serum estrogens, estradiol, around 25 to 30, pretty tight. I don't like seeing them when they're non-detectable, because you can actually precipitate bone loss in these guys if you're too aggressive with your aromatase inhibition. And yes, there are some botanicals that can work too. So remember to take care of the whole patient. Don't ignore the gut. Don't ignore sleep, stress. Don't ignore their micronutrients. and their exercise habits when you're contemplating testosterone deficiency. Thank you very much.
Thank you, Dr. Holthaus. We really appreciate all the wealth of information that you brought today. It's been fantastic just spending time learning from you, and we look forward to having you back in the future. You know, we're just about out of time here. So what we'd like to do is have our audience email their questions to info@dutchtest.com. That's info@dutchtest.com, and then we'll get back to you. There's been some good questions come through, and we can help out, you know, just helping people understand more about how to better take care of their patients, the providers take care of their patients. And once again, we have a great opportunity for new providers. You can go to dutchtest.com and click on the new provider tab, and we have 50% off up to 5 test kits for all of our new providers, and we'd love to help you in your practice. So thanks again, Dr. Holthaus. We really enjoyed our time with you, and hope you have a wonderful day. And thanks everybody for joining.
Bye-bye. Thanks, guys.
Thank you.